Okay, everyone, good evening and welcome to the third instalment of the SmileFast webinar series. Tonight we have the fantastic Dr. Jasmine Piran. Jasmine has been with us and as a lead lecturer at SmileFast from the start and has helped us train over 6,000 dentists with SmileFast Direct, as well as our other courses. Since qualifying from King's in 2004, Jasmine has achieved a master's degree in restorative and aesthetic dentistry and is also a lead lecturer for Invisalign. So we're in capable hands tonight, guys. Reap the rewards of what we are offering you. So don't forget, this is an interactive webinar. So please, throughout, if you pop your questions in the chat box, and then what we'll do is at the end, we'll do a short Q&A session. So without further ado, and I will keep you less bored with my Mancunian voice and hand you over to the wonderful Jasmine. Over to you.
Thank you, Lou. We love your Mancunian voice. It's a pleasure to listen to your lovely accent. Thank you so much, Lou. Good evening, everybody. I'm going to say a special thank you for being here today because it's the sunniest, hottest day of this year, I think, or even the last 12 months, it feels like. So anyone who's taking time out from this lovely bright weather outdoors and actually being on this call right now, I am super, super impressed. So thank you so much for joining. It's an absolute pleasure to be here, and I'm going to get started because I always like to reward those of you who are really punctual. I think that's yeah, just only the right thing to do. So without further ado, we're going to be talking this evening about understanding the pre-restorative position, and it's such a huge topic. It goes way beyond the scope of it goes way beyond what we can really kind of fully cover within this short webinar. But what I'm hoping to do is just to kind of whet your appetites a little bit and sort of hopefully give you some top tips to help guide you when you're planning your cases. So why is the pre-restorative position so important? Multiple reasons. We really want to make sure that we're providing our patients with the best outcomes possible. One of the things that's really kind of at the core with SmileFast and within the SmileFast family is that we want to be helping you guys to provide your patients with ethical cosmetic dentistry or restorative dentistry. So helping you to understand how to achieve the absolute best outcome possible for your patients is really, really important. We want to help you achieve optimum aesthetics and also function. It's not just about the aesthetics. Function is so important, especially when it comes to sort of ensuring maximum longevity for whatever type of restoration you're providing your patient with. So we want to make sure that you're able to provide or pick and provide the most appropriate restorative plan for your patients in terms of process, in terms of the restorative material, and also in terms of restoration design. Obviously, something that's really close to all of our hearts at SmileFast, and I think should be important to all of us as dentists working within this amazing modern era within our field, is that we want to, wherever possible, provide minimally invasive approaches for our treatment plans for our patients, and that's incredibly important. So understanding that pre-restorative position has a huge impact on your ability to actually provide treatment minimally invasively. As I've mentioned already, we want maximum longevity for whatever your final restorations are, and that involves avoiding functional chips and breakages, because those can become the bane of your life when you're doing this type of work if you've missed something in that initial assessment. And the reason that pre-restorative position is so important is that, we often see quite challenging situations like this. I'm sure many of you will remember this case from the pre-course learning or from the lecture that you attended whenever you've attended. This is a case that we often show at the beginning of the course, because you can see that here there are so many different ways that we could approach this case. And in actual fact, this case was approached restoratively in the first instance. So if you look at the teeth in their unprepared and then directly below in their prepared state, it's not a crime. It's not the end of the world. Far more aggressive preparations have been carried out. The preparations themselves, we've got nice margins there. However, it's not necessarily in this day and age the most ideal way of approaching this case. And, when you go for what I call ortho with a burr, rather than actual orthodontic alignment treatment for a case like this, then yes, there are going to be biological compromises because we're prepping the teeth, but there are also potentially going to be aesthetic compromises because, as you can see, the upper right three are so sitting so high up, so buccally positioned. So however much we prep that tooth, and we could prep back right down to blushing pulp, you're still going to end up with a fairly bulky looking canine, and the gingival margin profile on that teeth will be quite high. So there's going to be aesthetic compromises, as well as I said, biological compromises, and potentially some functional compromises as well. So ideally, we want to avoid these sorts of situations if we can. This is a case that was recently shared with me by the awesome Dr. Tom Seeley, one of our co-founders. We've got Dr. Mide Ojo online this evening as well, guys. So we've got royalty in the house. But this is, I think, a really interesting case, because you see a case like this, and again, unfortunately, patient didn't want to have pre-restorative ortho treatment, so restorative treatment was carried out. Beautiful preps. I'm sure everyone would agree, it doesn't matter if you like the color or not, everyone would agree that this is definitely aesthetically an improvement in the upper arch, certainly, and there's been some whitening done in the lower arch. So things are looking much better here when the restorations were first placed. And then you fast forward 15 years, the patient disappeared, didn't come despite recalls and everything being sent. And you fast forward 15 years after non-attendance, and this is the sorry state that they've come back in. Now, I'm sure there've been lots of different things and different factors that have led to this situation. But if you compare the lower arch with the upper arch, clearly there's some perio there. There's some, lots of things going on in both arches. But the upper arch, which is where the heavy preparation has been done, things are looking significantly worse. And I dread to think how things will look once you remove and dismantle what's there at the moment. Heavy, heavy breakdown on those upper laterals. And if you remember where those teeth were positioned beforehand, those were relatively palatally positioned. So what you've ended up with is quite thick restorations, big, thick restoration margins. So I'm not suggesting this is going to happen to every case. Of course, we would hope this won't happen. And of course, the hope is that we will maintain our patients and they will follow a nice, regular recall process after we place our beautiful restorations. But realistically speaking, what are those cases going to be looking like over the next 10 to 15 years? We need to try and educate our patients to prevent more and more of them from taking these very drastic steps and having these incredibly destructive processes done. And at SmileFast, that's always been one of our core aims, is to help you guys, sort of empower you, if you like, to help you be able to offer your patients a nice alternative path that can give optimum aesthetics, function, and biology long term to your patients, to prevent them from jumping off this cliff, as I call it, and having such heavy preparations done to perfectly healthy unrestored teeth at such a young age. The biological cost, let alone the financial cost, the biological cost here is incredibly high. So to be able to really understand that pre-restorative position and really empower yourself to make the best decisions possible and to give the best advice to your patients possible, it's all about understanding how to carry out a really comprehensive assessment and then treatment planning from that point. So we would always advise you to follow this kind of facially generated treatment planning pathway, as sort of pioneered by the Spear-Kotick model. And that means that you assess every case using a very methodical pathway, if you like. So you start by looking at the aesthetics, then you look at occlusion, then you look at structure, and then you look at biology. And what that means is that from an aesthetic perspective, we're looking at the patient's face, we're assessing midlines, proportions, looking for any asymmetry, checking smile proportions in terms of the smile arc, so the shape of the incisal edges relative to the lower lip. Where is the upper lip position? Do they have a high, low, or average smile line? How are the buccal corridors looking? What are the soft tissue factors? So what's the lip support like? The skeletal base, to gingival margin levels, all of these elements that contribute to the aesthetics of a case. Then we would suggest you should look at the occlusion. So both in terms of the static and the dynamic occlusion. So what are the molar canine and incisor relationships? What's the overjet like, the overbite like? In terms of dynamics, make sure that you're checking lateral and protrusive excursive pathways and see what's happening there. See if you can work out how particular wear patterns may have come about. Check centric relations, centric occlusion. Are there any discrepancies there? And then you're going to look at teeth. So the status of the dentition, the restorative status, is there any active disease, active caries? Is there any tooth wear? Is there any periapical disease? And then we look at biology. So what's the health of the periodontium, the bone levels, the root form, joint health, muscles? Is there any pre-existing recession? Do they have a thin biotype? Does that mean there's a risk of recession kind of going forwards? And this is a very basic kind of structure that your initial assessment ideally would follow for all patients. So not just someone who comes in and says they want a smile makeover. It would be great if we could all just get into the habit of actually assessing our patients using this very methodical approach. If facially generated treatment planning is something you've never heard of before, then I would urge you to take a screen grab of this reference, because that will take you to a fantastic paper on the subject. It's a really easy way of approaching your cases once it becomes automatic. As with any new technique that we learn, it can feel a bit clunky to begin with, but it can work brilliantly. And if you get your nurse involved as well, that would make your note-taking process much faster, because your nurse will just have a pro forma that they read through, and then you are calling out the answers, and the patient gets involved as well, and it becomes this wonderful co-diagnostic process. You'll get much better engagement from your patients, and they will show genuine interest in understanding what's going on in their mouths and understanding what their treatment options are in terms of fixing things. So in terms of designing a patient's smile, really, really important that we're just assessing your patient's face and their smile in full, so that we can plan all of these elements, you know, the midlines, the gingival margin levels, upper and incisal edge position, tooth proportions in terms of height to width ratios, buccal corridors, teeth alignment, tooth shade and shapes, and embrasure shapes and sizes, because all of these elements will be important when it comes to actually carrying out that full initial assessment and understanding how to plan your treatment. And I have to say, it's not all stuff that I would say I can always assess there and then fully on the patient in the chair. I do, but I also need to rely upon really decent, good quality photography as well. And remember that there are the basic 8 images that we require for all cases that you submit, and these have to be taken in high quality form. So, you know, these full face images, don't be taking those images with the patient lying back on the chair, you kind of leaning over the top of them. We want to be able to carry out this level of analysis on the photos that you are submitting. So just do make sure that you are submitting really good photos. Remember that if you are still maybe feeling a little bit lacking in confidence when it comes to photography, you can obviously attend. There are multiple photography courses out there being run by incredible clinicians and colleagues from our wonderful colleagues. But there is also, there is also a fantastic, I think it's probably about 30 to 40-minute video created by one of our own from the SmileFast family, Dr. Rajiv. He's taking beautiful photos and has a great setup within his clinic, and he's done a video that you can access on the Google Drive. So please remember, if you're still kind of struggling with your photos, then there's lots of help available for you. The most important thing, I think, when we're planning these sorts of cases is to really work on getting your eye tuned in, because you can't see what you can't see. So you will only see things when your eye is tuned into looking out for certain nuances. And this is something that we get better and better at the more that we practice it. So for example, in terms of smile design, things like midlines, spot the midline issues, spot when there's a cant, okay? Because a cant can really have an impact on aesthetics. Spot if there might be a cant and a shift in the midline, and spot if there might just be a shift in the midline, remembering that actually a physically shifted midline that's still parallel to the facial midline is probably going to be much less disturbing to the eye than a canted midline. So these are all elements that we need to kind of get used to spotting. You also want to understand what you're looking at and what's causing it. So for example, if you have someone who's got a particularly gummy smile, what's actually led to that happening? Is there just naturally a high lip line? Does the patient have quite a sort of a long or a tall kind of maxilla? Is there a facial proportion issue? Do they have a increased lower face height? Or, as you can see on the right hand side, do you have a situation where potentially this patient probably didn't originally, when the teeth first came through, have a gummy smile, but there's been so much heavy tooth wear that we've ended up with compensatory over eruption. This is somebody who has a very high usage of recreational drugs, and so they grind their teeth very heavily at the weekends when they're out partying, and this has led to this level of tooth wear in a relatively young patient. This patient was in his very early 30s when I took that photo. So we basically need to channel whatever your most favorite detective is, and we need to use our powers of detection to kind of peel back the layers and understand what has happened, what has led to the situation that we are faced with clinically. And I'm going to give you an example of that. So this is a guy that came to see me. He was very young. He's 24 when I took this photo, and he came to see me actually under duress. So his girlfriend, who was a patient of mine for whom I'd done some composite work, she kind of dragged him in, and he came in, and I was the third dentist that he was seeing. And the only reason she managed to convince him to come and see me was because the previous two dentists that he'd seen, remember he's 24, the previous two dentists that he'd seen about his main complaint, which was the uneven heights of his upper central incisors, the gumminess on the upper left one, and the uneven tooth heights, two sizes of those two teeth. The two previous dentists had told him that the best way to fix that, the only way to really fix it, was with crown lengthening, so periodontal surgery. And in my opinion, quite understandably, he wasn't so keen on that as a solution. He didn't like the sound of having to have surgery on his gums. Thankfully, so his girlfriend told him to come and see us. And what I sort of decided that I felt like it was was happening here, what I diagnosed was that he had a bit of a high lip line, but also that it was being the situation between his upper centrals was being exacerbated because there was some compensatory over eruption happening on his upper left one, because actually he's quite class 2 skeletal, and his upper left one is existing and functioning in a very much class 2 div 2 sort of restricted envelope of function situation, and the upper right one is like it's in class 2 div 1. It's kind of quite procline and flared out, and it's not really doing much. So all of that function, all of that kind of guidance is hitting the upper left one. And so even though he's only 24, that tooth, because it's quite retroclined, is wearing away palato-incisally, and then there's some compensatory over eruption taking place. Now what that means is that if he did go down the path at the age of 24 of having periodontal surgery, crown lengthening surgery on the upper left one, if the underlying functional issue isn't being resolved or managed, then potentially that recession, or sorry, not recession, the opposite of recession, that over eruption is just going to keep getting worse. It's going to grow back again, or not actually grow back, but that tooth will continue to over erupt, and the gingival margin will continue to come down with it. So we saw him, and obviously he doesn't like what the previous two people have told him, but the fact that they agreed with each other made him think that there might be some truth and some legitimacy to that. So we see him, and we're saying it's something completely different. We're giving him a completely different suggestion in terms of how best to manage this. And so it helps that we've got lots of digital tools that we can use and visual aids to help us to sort of guide the patient in terms of justifying this new different treatment plan that we are proposing for him. So we use digital treatment planning, and we suggest that he does some alignment treatment and that we improve the anterior envelope of function. We procline that retroclined upper left one, we upright it, and most importantly, we intrude it to get it back up to where it's supposed to be. So we align the gingival margins, and then on the right hand side there, we've had to simulate what we would do restoratively, because obviously he doesn't like how he looks in the image on the left, but he's also not going to love how he looks in the image in the middle there, right? Because yes, the gingiva are nicely aligned, but the edges look all over the place. So we have to be able to visually show him what we're proposing for him, both orthodontically and restoratively. Now, the beauty of this type of digital treatment planning and modern orthodontic techniques is that we can actually give him a really predictable idea of what he's going to look like from the outset before he even commits to treatment. So if we compare pre-op, post-alignment and post-restorative actual outcomes with what we proposed in the outset, you can see that they are very, very similar. And so that predictability is really great. And of course, as you build up your case portfolio, we can show patients other people's cases in this same way. So we can prove really that as long as they comply and we plan our cases well, we're going to be able to give them quite predictable outcomes. Now, if we look slightly more closely at his case, so when we look at the lateral views, that's where you can really see what was going on with him and that restricted envelope of function around his upper left one. So you can see that obviously he's done some whitening as well, but we've aligned those teeth and then restored them. And this is all possible. this is all the kind of treatment that your patients will engage with, because we're able to kind of use this co-diagnostic method, if you like, as I said, calling everything out, making sure the nurse can hear, and it's the patient can hear, and the nurse is typing everything down or writing everything down for you. But we've got so many visual digital methods that we can use now to really help our patients understand what the blueprint of what we're designing for them is. Because the reality is, you would never try and build a house without planning where to put the bathrooms and the kitchen. We would never do that. So we should take that same approach when we're planning how to give our patients a beautiful smile, and incorporate all of the kind of elements into our plan from the very beginning. I've lost count of the number of times I might be mentoring a colleague, and I'll ask, either at the alignment phase or the restorative phase, well, what's the plan? Let's say we're aligning the teeth. What's the restorative plan at the end? And they'll say, oh, well, we're just going to align the teeth first, and then we'll figure out what to do restoratively at the end. That doesn't really work. We need to plan everything from the outset to get optimum outcomes, and make sure that we're planning everything meticulously for optimum function and aesthetics at the end. Because the reality is that even that 24-year-old who was relatively unrestored is going to be presenting with what one of my lovely mentors, Dr. Raman, who's a specialist orthodontist, they often present with varying degrees of dental baggage. People are not presenting with perfect teeth in perfect mouths. And so often just one single problem being resolved is not going to be enough to actually give them the final aesthetic outcome that they want. So what he means when he's referring to dental baggage is various different components within that patient's dentition. They might have a heavily restored dentition. They might have caries or a history of a high caries risk. There might be periodontal disease, either current or historic, which has been stabilized. There might be recession, missing teeth, shifted canted midlines, tooth wear, discolored. These are all examples of what we call dental baggage. They're all elements that patients might present with that they might be completely unaware of. They might come to you for one specific thing, and we might have to then break the news to them that there's a lot more going on in their mouths. And it's much easier to do that when you've got a really good digital workflow. You've taken decent photographs. You can put together a little kind of presentation like this and actually present it to them. And I always say, I'm going to take you on a guided tour of your own mouth. These days, with fantastic scanners, you may not even have to put these still images together into a report. You might literally just be able to sit down in front of a digital scanner, a 3D scanner, and just go around that patient's mouth and show them what's going on in each sort of part of their mouth. And that has a big impact, because it adds legitimacy to what you're telling them, and it helps them to really engage with what we're seeing. Always a nice idea to annotate images and show them things so that they can see specific things that might come really easily and quickly to you because you've got your eye tuned in, and maybe not necessarily to them because they're not used to it yet. So you want to be able to show them what's going on, and then ideally give them some kind of augmented imaging or motivational imaging that will help them to understand where you're proposing to take them. The reality is, if someone's come in to see you for restorative work, and you're telling them, yes, we can do the restorative work, but we're going to have to do some alignment work first, we really need to be able to show them why and how that all fits in. There will be some patients that will take your word for it without having to see all of this, but often people are coming to see us for this type of work, and they're not necessarily already pre-existing patients. And so it does make a big difference when we're trying to actually help them to understand that they can trust us and they can learn about what's going on in their mouths. This level of kind of detail and annotation really can make a big difference. So we're seeing an increasing number of patients who present to us with aesthetic concerns, but whose treatment process and outcome could really massively benefit from some pre-restorative alignment of the teeth. And we're moving away, I think, in this country from what I referred to earlier as ortho with a burr. And we're starting to kind of really understand that there are so many different elements of a case that could be optimized if we can incorporate some ortho. So aesthetically, we can do things like you just saw in the case I just showed you. We can improve gingival margin symmetry. We can improve buccal corridors. We can create space to balance out tooth size discrepancies. All of these things are now relatively straightforward with modern orthodontic techniques. From a functional perspective, notice how big this box is, guys. Function is so important. Tooth wear is such a prevalent dental disease, I think, in our patient base right now. And as soon as we start restoring teeth, if there's a history of tooth wear, then as much of the historic tooth wear is not our kind of responsibility, any future tooth wear becomes our responsibility because we've placed restorative work in that patient's mouth. So function is really important, and we can often improve the envelope of function pre-restoratively, and that will often then improve the longevity of our final restorations. It can also improve restoration contour and thickness. Remember the case I showed you that disappeared for 15 years. Imagine how much lower the risk of such huge breakdown in those lateral incisors would have been if the restoration hadn't been quite so thick. So improving restoration contour and thickness can make oral hygiene maintenance much easier in the long term, reducing the risk of complications further down the line. From a structural perspective, obviously, we know that especially if there are teeth which are crowded, rotated out of the arch, then if we can derotate them and improve their position, that will reduce the amount of tooth preparation that might be required. Also, and again, this all goes hand in hand with what I was saying about how as a family of a team at SmileFast, we really are focused on helping you to provide ethical treatment for your patients. You may actually find that you can get away with restoring fewer teeth if you align the teeth first. So we're not in it for the numbers, we're in it to help you provide really excellent top standard care for your patients. So restoring fewer teeth would have a lower restorative and biological cost for your patients. Again, the hope is that you can improve the longevity of restorations and reduce the risk of breakages. If you're not prepping the teeth so heavily, then potentially there's a lower risk of pulpal sequelae further down the line. And then, of course, from a biology perspective, if we're restoring aligned teeth, that's going to improve restoration contours and profile. It's going to improve oral hygiene, access, and potentially reduce the risk of perio and caries complications further down the line. Less invasive preparations, as I've said, less likely to cause pulpal complications further down the line. So having some ortho incorporated into your plans can really make a big difference. But of course, the challenge as we live in this time where everybody wants everything instantly and immediately, the challenge is that you'll have some patients who come in asking for restorative work and you have to tell them that they might need some ortho first. And then you have the ones that come in asking for ortho, actually, funnily enough, who need restorative either first or at the end. You know, they might think that all they need to do is straighten their teeth, but straightening the teeth isn't necessarily going to give them that beautiful smile. So often what we're having to tell these people is that on some level, they need a bit of a multidisciplinary approach. The beauty of it now is that with modern techniques and technology that's around, we can actually be a multidisciplinary clinician ourselves as long as we're working within our scope of practice. So that challenge is that you're often faced with a negotiation because you're having to say to the patient, look, I know this is what you came in asking for. I know there might be dentists in other places, either in this country or abroad, who would give you that immediate result. But ideally, what we're seeing is a situation whereby you might need ortho first. And hopefully you don't get the tantrum that you can see in the image on the right, because you're making use of that co-diagnostic workflow where you're actually taking the patient on a journey, taking them along with you and helping them to actually almost sometimes come up with the conclusions themselves, because logically, when you show them what's going on, they are going to sort of buy in, if you like, they're going to understand. So something I think there's been a bit of a paradigm shift with is that and one of our wonderful colleagues, Miguel, I'm not sure if he's on the call yet because I know that he's working till quite late today, but when you tell your patients that they might benefit from some orthodontic treatment, what do you think they actually think we're talking about? Because even now, even though, you know, there's Invisalign is a bit like Google, it's become a household name and concept. People still often, when we say they need ortho, are thinking about this. They're thinking about 2 years. They're thinking it might need extractions. And as Miguel would say, they're thinking they might need to donate a kidney or something. You know, ortho was this huge palaver always. And there are still cases that require this level of approach. Absolutely. I'm not suggesting that specialist comprehensive orthodontic treatment is no longer a valid or important part of our profession. Of course it is. But what we see is that there are lots and lots of cases, especially people coming in primarily asking for restorative solutions. There are lots and lots of cases that can be managed really well with modern discrete alignment systems that can give us very predictable and efficient results, as you saw with this case that I've already shown you. So here, for example, we didn't just align the gingival margins. We've actually done significant functional work for this patient as well. Remember, he's 24, so we want to try and give him as an ideal an outcome as possible. But we've corrected bilateral scissor bites. He had the cant in central between the centrals. We've resolved the crowding. Obviously, we've aligned his gingival margins, and we've improved his envelope of function in just 9 months. Ideally, I would have carried on a bit longer and improved that deep bite just a little bit more for him. But with these cases, you'll often find that you'll reach a point where patient's done, they're happy, they can see the benefit of having had the alignment, and they've reached a point where they're about to fall off the wagon in terms of compliance, and they're super happy with where we are, so they just want us to get on with the icing on the cake, which is to give them that final restorative outcome. So this is the thing we need to be aware of, is that patients don't necessarily always know what we mean when we're referring to some pre-restorative alignment. And that's the paradigm shift that we need to kind of bring about for our patients, so that they make educated, optimum decisions for their own oral health. So let's look at some common clinical scenarios. One that we often face, we're often seeing cases on the portal, are cases like this. So we've got a patient coming in and they want us to restore their teeth, and there's some crowding present. So you can see here you've got quite crowded areas around the upright 1 and 2 there. And the question is, do we align? Do we prep? This patient was in her mid-70s. Does that affect whether or not we offer alignment? I would say not. We would still offer alignment, because some of my best patients having alignment treatment now are currently in their 60s, 70s. They're the ones who really follow the protocol, and they're fully invested in the process, and they're less time sensitive. Ironically, later in life, they've become a bit more patient. There's a contradiction there. But do we want to prep, or do we want to align? So this is an example. Some of you will remember this case from the pre-course learning or from the lecture day. This is a dentist. So this dentist, obviously dentists are not necessarily always the most ideal patients. We're often the most impatient and the least compliant with whatever plan we're being advised to follow. So this patient didn't want to have alignment. So this patient opted for prep. And in a situation like this, how do we know how much to prep? Well, we can see on the left-hand side there with a 3D setup, that's the SmileFast Refine setup. You can see the natural tooth, that upper left one, is coming out. It's kind of extending beyond the proposed digital wax up 3D setup for those final restorations. And in a situation like that, obviously, ideally, that patient would agree to alignment. I would say it's a shame not to. Patient didn't want to. And so in that situation, we're going to prep the teeth. And you can either use digital techniques or analog techniques to help you understand where the prep needs to be. So in the case of the dentist that I just showed you on that left-hand side, the upper left one is going to be needed. It's going to need to be prepped back a little bit. In the case of the case on the right-hand side there, you can see we're checking to see with a putty, a palato-incisal kind of putty matrix, to see how much restorative space we're going to have around the teeth. We're holding that against the patient's starting teeth, and you can see around that upper left 3 there, we're a little bit tight on space. So you might need to do a little bit of prep on that upper left 3 there, or perhaps have a 3D setup done that actually involves slightly more addition to that tooth to allow for the fact that that tooth is slightly more bulky. But we can use either analog or digital techniques. And this is a case that was done by one of our wonderful dentists in the Centre of Excellence. He's a Centre of Excellence clinician for SmileFast. And you can see that you have a situation on the top left there where the teeth are quite crowded, especially, again, just like the case we just saw around the upper right 1 and 2. And the reality is that this case will really, really benefit massively from a little bit of ortho. It doesn't have to be absolutely perfect, but you can see if you compare the pre-op with the after alignment, we've got a significant improvement in the position of the upper right 1, 2, 3, and 4 on that side. And that then has a huge impact on the outcome restoratively. So once the SmileFast Direct has been placed, everything looks really great there because of the fact that the teeth that were crowded have been improved. It's not just that we're going to have to prep those teeth. You would have to prep the upper right 1 distobuccally quite heavily. If you didn't do the ortho, you would end up with quite a thick, bulky restoration, a thick incisal edge on the upper right 2. You might get some shine through of the upper right 3 because it's quite buccally positioned, or you might again end up with a very thick, bulky restoration on the upper right 4. So just by improving those small elements with a relatively short course of orthodontic treatment, we can actually improve the aesthetic result, as well as massively reducing the amount that we might have to prep those teeth before placing our final restorations. So crowding is a very simple example of how we can improve things with some pre-restorative alignment. What does really matter, and I will keep kind of hammering this point home, is that if you do this kind of a short course of alignment treatment before you place your restorations, then retention is absolutely paramount, because it takes a long time for the fibers around the teeth to get the memo that we're no longer moving them. And the risk, of course, is that they will relapse, and your beautiful restorative phase will then be compromised, because those teeth will start relapsing back to their previous positions. But on the whole, it's important to note that in a situation like this, you don't necessarily have to aim for perfection. Just a significant improvement is often enough to give us a great restorative outcome. Something we see a lot on the portal is these sorts of situations. So we see a lot of patients presenting with very heavy tooth wear, and there's an underlying class 3 situation going on here. And the patients come in wanting us to restore those teeth and make everything look beautiful. And the reality is that it's really, really difficult, because where are we going to place our restorations? There's no restorative space there at all. So there's a number of red flags to look out for in these sort of situations. Class 3 skeletal patients, class 3 incisor relationships, crowding that's more severe in the lower arch than in the upper arch. You can see that quite clearly here. Often I find these patients, just like this lady was, are adamant that they want to avoid extractions. You can imagine just a simple lower incisor extraction would have really massively helped us here to sort of balance out the anterior occlusion there. So they have a very, very tight overjet. And often if you're planning ortho, you will be in a situation where you'll see that there's a lot of IPR required in the lower arch to resolve the crowding and achieve a positive overjet to create restorative space so you can restore these teeth. And yet still, even with maximum IPR, you may not yet still be achieving a decent enough overjet to create the restorative space that you need. So this can be a really challenging type of case. And often these patients come in not necessarily asking for ortho. It's quite rare that I find they come in asking for ortho. Usually they're coming in complaining about recurrent chipping. And this lady came to see me because I used to treat, or in fact I still treat, her stepdaughter, and I'd done some composite work for her stepdaughter. So she came to see me because she thought my composite was going to be different to somebody else's composite that kept chipping on her upper incisors. And I said, look, as much as I love composite, nothing I place, it's probably not even going to last as long as it takes you to leave my building, because there's no space for me to restore those upper centrals. They were her biggest complaint at the time. So a restorative only approach for her is so much more than just some edge bonding, isn't it? It's going to basically need a full mouth rehab. She's going to have full mouth rehab, opening up the OVD, potentially restoring every single tooth in her mouth, which of course she doesn't want. She doesn't want that at all. So some pre-restorative alignment work for her gives us a fantastic alternative. It's a much less invasive solution, as long as the patient is on board with it and they're going to comply with the plan. So if we look at what we did for her, she started out, as I said, class 3 edge to edge with anterior crossbites, absolutely zero restorative space and very heavy tooth wear. In terms of the alignment, we've managed to achieve a positive overjet. That's absolutely key. Really, really important, because without that, we won't have the restorative space that we need. And then we've done some simple composite restorative work. She was actually given composite restorations at the time, about 5 years ago now. And I sort of really gave it to her with the caveat that because of how heavy her tooth wear was, I really said to her, look, I expect we're going to have to convert these to ceramic within the next couple of years. So we're now 5 years on and things are still looking pretty great. So we've managed to give her a much better anterior occlusion, possibly a slight gap opening up there between the upper centrals. I think that's because everything's kind of settling occlusally for her. But nevertheless, she's overjoyed, and we've not had to do anything to those restorations. They could do with a polish, absolutely. But if you think about how she started versus how she ended up and how relatively stable that end result is for her, it's made a huge difference. And of course, you'll often find that when patients have this type of work, they often become so much more confident about their smile that they go and actually enhance, they draw attention to their smile by, for example, as she did, adding volume to their lips. So this type of work is absolutely life-changing for your patients. She comes in now with, bright neck scarves and lipstick and things like that on. It's given her a completely new lease of life, and it's had a age reversal effect as well for her. And we've managed to do that in a relatively non-invasive way for her. So This is another example of a similar case, a much younger patient. This chap was 29 when I first saw him. And again, he wanted me to place composite because he was finding that the composite kept chipping whenever his dentist was placing it. And again, I assured him that I do not have heroic composite status. There just simply isn't enough space within his occlusion for that to fit. So he started out asking for composite. We ended up explaining to him that really he needs some alignment, or he would benefit from it. A good option for him would be some alignment treatment first to achieve a nice positive anterior overjet, so that we can then just simply give him some new edges. Because if you were to leave him as he is in that top row, then this is the beauty of this type of treatment, I think, is that if we were to leave him like that, how would he end up in another 10, 20, 30 years? These are the cases that we're all, not all of us, but often we're kind of too scared to start, because the teeth, we're just watching them every 6 months getting shorter and shorter and shorter and thinking, gosh, but I'm going to have to do a full mouth rehab on you. And that's a massive process. So I don't want to do that. So I love the fact that by just spotting the problem, we can intervene with some ortho and then sort of reverse the problem and prevent bigger issues in the future. The most important thing with these cases, though, is to take a really close look at the anterior overjet view. So if you look at those two images on the top right, that's the scan and also the ortho planning pre-op position of the anterior overjet view. It's like the chin up view. So you can really see why he's got such heavy wear there. And it's important when you're planning those cases to make sure that you're factoring in sufficient retraction of that lower labial segment in order to achieve not just a positive overjet, but one with a little bit of incisal clearance and space, so that you then have space to restore those edges. So that bottom scan on the right is after restorative. That middle image on the right there is at the end of ortho. That was what we were aiming for, basically. So if you're dealing with these class 3 situations where there's a lack of restorative space and you want to go through ortho, then I would say these are the kind of top tips. You want to always make sure that you're aiming for a positive overjet, at least 2 millimeters if possible. Factor in sufficient anchorage, so important. So that might mean using class 3 elastics. You might want some horizontal rectangular attachments if you're using aligners on the molars. You might want to make the molars unmovable, because that can increase the anchorage of the system and help you to really focus on the movement you're trying to achieve at the front. I find often with these patients, their posterior occlusion might be fairly stable. One of the reasons we don't want to maybe think about doing a full mouth rehab for these cases is that there's no evidence of posterior occlusal disease. Their posterior dentition is intact and not worn. Everything's going wrong anteriorly for them. That's where all the tooth wear is happening. So often we can actually plan these cases without really moving the molar teeth, and that can increase anchorage, which in turn makes your anterior tooth movements much more predictable and efficient. Often these cases have quite heavy IPR programmed into them for the lower arch, whether you're using fixed or removable appliances. You'll often find that you need to do quite a lot of IPR. It makes sense, right? We're trying to reduce the overall arch size of the lower arch. That means we need to reduce the dental volume. That means we need to add IPR if possible. And so what I often find is that people don't like doing IPR, understandable, but that means they don't do all of the IPR. They underperform the IPR, and then you don't quite get things tracking. And one thing I would say that's really important with these cases where people come to us for restorative work and we're saying, oh, we need to do some ortho first, you need to make sure that your ortho phase is effective and efficient. And so carrying out all of the IPR that's planned is really important. If you're finding that you're looking at a case like this, which is a class 3 case, edge to edge, and you're still, even though you're doing lots of IPR, you're still not looking, it's still not looking in the planning stages like you're going to have a decent overjet, then I would definitely also plan a version of the plan where you plan for an incisor extraction. A lower central incisor would normally work best. So always look at all the different ways of achieving this, because what you don't want to do is carry out maximum IPR, not have incorporated sufficient anchorage into your planning, and then you get to the end and you still don't have restorative space, because that's a disaster. So it's important that you do whatever it takes to make sure that you're definitely going to have an effective orthodontic outcome pre-restoratively. Keep going until the required orthodontic result is achieved, both aesthetically and functionally. So don't just do a really short course and go, well, we did the ortho. You've got to get the end result that you needed to get to then be able to actually benefit from that orthodontic course of treatment within your restorative phase. So keep going, and always plan for long-term retention around your restorative workflow, because those cases are what I call a flight risk, because we've done the alignment, then we're restoring, patients suddenly love their smile. You've got to make sure that you're factoring in sufficient retention for them. And remember that ortho isn't always the answer. So this is an example of a case that, again, really young guy. He was in his mid-30s at this point. I think he was 34, 35 when I met him. And this is how he presented. And you can see there's lots going on. He's lost posterior support. Yes, absolutely. But not everybody who loses posterior support is going to wear their anterior teeth down to such an extent. So he had a very stressful job. And so he was grinding his teeth very, very heavily. We can practically see the pulp space on those upper centrals there. So this is an example of a situation where, yes, possibly ortho may have been of some use, but how long would that have taken? How would it really have helped us? How would we have factored in sufficient anchorage to do a significant level of improvement by incorporating some ortho for this patient, who, by the way, was incredibly nervous? So we don't always incorporate ortho. We only incorporate it when it really makes sense to do so. If we look at him, we used a partially digital workflow with the SmileFast system for him. So you can see just we recorded his pre-op situation in CR, and then those scans were printed off and mounted on a DNR articulator, and then an analog wax up was initially carried out for him. So we did his trial smile like this, and then we wanted to use SmileFast to deliver it. Obviously, we wanted to modify that ever so slightly as well. We did end up doing some laser work around the gingiva and lengthening the teeth slightly as well. And so this was where he ended up using the SmileFast Direct workflow. And we actually restored upper and lower on the same day. He lives very, very far away. And this actually lasted really, really well for him. We only ended up upgrading the uppers to ceramic after around 4 years. And there wasn't a real need to do that. It's just that we'd said to him at the outset we were going to do that. So he kind of psyched himself up for that. And he wanted to go for a supremely bright shade. I think he probably could have gone another couple of years at least with those same restorations and been absolutely fine. And the impact it had on him and his confidence, I'm trying not to show his full face here, so you can't see it, but if you could see his eyes, it's like he's a different person. It's made a really, really big difference for him. So these edge-to-edge cases, often I find ortho can be a huge help, but not absolutely all the time. So don't, just because we're showing you situations where they can really help, don't assume that that means that we have to kind of think about ortho all the time. I'm just spotting a couple of questions in the chat box. I'm going to just check and see if there's anything I need to answer. 1 second, guys. Oh, no, it's just you guys being told to answer. Oh, there are in the Q&A. Midi, do you want me to answer some questions, or are they being...
I think we can do them at the end, Jasmine. So
okay, fine.
then we
Perfect.
can answer them live.
Perfect. All right. Thank you. All right. So I'm going to move on from class 3, which is something that we see a lot of, to these kind of restricted, reduced envelope of function class 2 situations, because we see a lot of these as well. This is another patient that we put through on the SmileFast treatment pathway. He was about to get married. Very young guy in his mid-20s. He was about to get married. So of course he comes, he gives me about 6 weeks until his wedding. It's often the way. And you can see that he has tooth wear. Actually, can you really see there? Let me show you the next page. There we go. So you can see that he's got this kind of class 2 div 2 situation, very tight, restricted envelope of function. He's got some tooth wear on the edges there. Most important thing here for me is this. And in a minute, you'll see his pre-op. He's got quite a lot of edge wear on the anterior, upper anterior and lower anterior teeth. So as much as I want to help him for his wedding, I'm quite mindful that we're in a situation here where we've got a restricted envelope of function, which means I can give him beautiful restorations and I can do it quickly, but there's quite a high risk of restoration factor if we don't think about the envelope of function. So of course, I suggest ortho. Like I said, we've got 6 weeks till his wedding, so that wasn't really an option. I even said, look, even if we don't improve these kind of retroclined, low-hanging upper incisors, would you at least consider doing some ortho on your lower anterior teeth, just to kind of retract things in a bit, increase the overjet there after your wedding to improve the longevity of your restorations? Unfortunately, he said no. I play you through his 3D setup here so you can see. Hopefully you guys will do this when you get your web link from the lab, because they have painstakingly imported your photos and scans into one platform so you can have a really close look and see what's going on. You look at it from all sorts of different angles, increase opacity or make them more translucent so you can really look at function. You can see here he's got quite a deep bite. quite jagged, worn edges. And like I said, he was really young. So a patient like this, I'm thinking it's not just about how you look right now. Look how uneven his incisor ledges are. It's not just about what you look like now. It's that what are we going to be doing with you, or how is it going to look if we leave you with this same envelope of function over the next 10, 20, 30, 40, 50 years. So we have to factor all of that in. So we want to make sure that when we're looking at the case, when you're sent the link from the lab to check, make sure that you're looking at everything from all of these different perspectives. So if I show you here, this is how he started. You could see he had a tendency to kind of posture forwards and sit edge to edge on the upper left one, lower left one. This was his trial smile. And then on the right-hand side, that's on the day that we delivered his restorations. We also added a bit to his canine tips there just to kind of try and improve guidance and try and protect our anterior restorations. At the end of the day, though, this is a classic case where he basically refused to kind of have the treatment that we were recommending for him. But the good thing was that because we did our thorough assessment initially, we actually warned him preoperatively that there was a high risk of fracture and chipping. We gave him a mouth guard to wear at nighttime, and we strongly advised ortho pre-op. We also strongly advised lower arch ortho, which is not something I would normally recommend, but in his case, because of the wedding, I was like, look, maybe we could just do short course of lower arch ortho at the end to help with your envelope function. He refused all of it, but it's all in the consent. Forewarned is forearmed. He knows it could happen, and if it happens, it's not my fault. He knows that. He's taken ownership of that. This is the risk. So if we don't forewarn, if we don't first identify and then forewarn patients of these things, then when it all goes horribly wrong and starts chipping, we don't look like we know what we're talking about, because we're starting to kind of backtrack and say, oh, well, it's happened because of this reduced envelope of function, but I never actually identified it and told you about it beforehand. So it's quite tricky. Another kind of class 2 situation here, you can see a patient that has quite a narrow arch, and he's got ongoing repeated wear happening, a very deep bite, reduced envelope of function, lots of ongoing pathway wear. We did an orthodontic setup for him. He was actually a very non-compliant patient, bless him. He would wear his aligners for hardly any hours every day. It was just, yeah, he wasn't really that compliant. However, despite that fact, we did still manage to, over the course of a few months, actually bring about significant change and create some restorative space so that we could then actually restore his teeth. So once he'd kind of got to the end of his tether with the alignment and he just said, I'm just not going to do any more. Obviously, I would have happily carried on because I'm a bit like that. But we then managed to get a restorative setup done. We got him into CR with a leaf gauge at 1.5mm thickness, so we could add to all of the teeth. And we knew all along this was going to be full mouth rehab, but we just wanted to try and improve the situation orthodontically first, because that was then going to improve and reduce the amount of prep that we might need to do for him. And you can see, by far not nowhere near ideal, but still a big improvement on how he started. And functionally, most importantly, functionally, this patient actually only agreed to have ortho because he was chipping and wearing teeth down on a weekly basis and was very sensitive to rough edges in his mouth. So he was literally coming in for a quick polish almost on a weekly basis. And ever since we've done this, we see him every 6 months and everything's a lot more stable. So sometimes we have to accept a very, very much compromised orthodontic outcome, but nevertheless an improvement on the situation. And that helps us with our restorative phase. So when you're dealing with these reduced envelope of function cases, these class 2 situations, I'd say the key points orthodontically when you're planning are, again, aiming for a decent overjet. I would say in these cases, aim for 2 to 4mm. Aim to reduce the deep bite, because often they've got this restricted envelope of function because they've got this kind of constricted deep bite situation going on. So you want to try and reduce the deep bite, but make sure that you're factoring in the upper lip position, because if you improve the deep bite purely by intruding the uppers in a patient who has a relatively low upper lip line, you're going to end up adding that length back on restoratively for aesthetics anyway at the end. So ideally, you need to look at smile aesthetics, and often you want to be planning to actually intrude the lowers significantly as well. When planning to intrude anterior teeth, make sure that they're at optimum inclination. So make sure you're proclining them first. If you're leaving them in a retroclined position and trying to intrude, that's going to be a very difficult movement to actually happen. It won't express. And so then you won't achieve what you want to achieve. Often these people have very uneven gingival margins. Sometimes they have quite a high lip line as well. And so you want to try and align the gingival margins. That's going to be part of your kind of correcting of that compensatory over eruption. It will probably lead to uneven incisor ledges, but you're usually planning on doing some restorative work. That's why you're doing this in the first place. So that isn't really a problem, as long as the patient is expecting that to be the situation during their orthodontic treatment. So you're aiming to really improve and open up that restricted envelope of function, and planning, as always, for long-term retention around your restorative workflow. And again, continue with the ortho until the desired end result has been reached. Don't just go through kind of one phase and think, oh, well, we've tried. If you haven't achieved the functional and aesthetic changes that you needed to, keep going. Unless you have a patient who's just like, not very compliant. That can be a problem. But ideally, keep going until you get to where you need to get to. This is another case. This is actually one of Tom's cases, and this is a patient who had a reduced envelope of function, and the patient didn't want to have ortho. So here we have that same class 2 div 2 situation, and he went straight to restorative. You can see top left there, that's the pre-op situation. 2019, the restorations have been placed, and quite interestingly, 5 years post-op in 2024, it's all actually still looking really good. One thing to notice, the reason this case worked was because when the treatment was done in 2019, you can see that we've got restorations placed upper 2 to 2, composite veneers, but also canine guidance has been reintroduced. We've got canine tips rebuilt on the upper canines, and that has really helped to safeguard the edges of those restorations on the upper 2 to 2. And at 5 years post-op, the upper 2 to 2 still look great, but look at the wear that's coming back in on the upper right 3. So functionally, he's still grinding and he's still kind of functioning off those canines. But as the upper right 3 gets shorter and shorter, that's then going to cause a risk to chipping of his upper 2 to 2. So we don't want that to happen. So it's important that we're monitoring these cases, spotting those sorts of small areas of breakdown, and then going back in, because that leads to a loss of canine guidance. So going back in, using optimum bonding protocols to actually reintroduce canine guidance and rebuild that wearing canine tip. So again, when you're repairing old composite, it's important to sandblast, etch. Be careful if you've got exposed dentin, which you often will do, I would say, on these cases. I would say a maximum of 10 to 15 seconds of etch on the dentin, and then use composite primer, and then a new composite layer, eliminate the oxygen inhibited layer by curing through the gel, and then polish again. And that will then mean that you've kind of safeguarded the upper 2 to 2 for just that little bit longer. So really important that you're analyzing, that you're analyzing and assessing function. So that's an example of a case where function was assessed pre-restoratively and built into the plan at the time of placing the restorations. And then again, it's been reassessed and managed clinically at review visits. Very important. So that will help you achieve maximum longevity for your restorations. Now, that works. This is an example of a really nice case, actually. This was, on the surface of it, it looks like a relatively simple case, doesn't it? Pre-op, we wanted to place restorations on the upper 2 to 2. This is actually a case that was sent to us by a delegate from the course. So it's easy to look at a case like this and just assume it's going to be fairly simple. And just to assume that maybe that little area of chipping on the upper left 2, maybe that's what I call a glass injury, when someone either bites their nail or knocks their glass into their teeth. And so you assume that's nothing major, it's not too significant, until patient comes back 2 weeks after the restorations were placed and they've chipped the exact same spot, although they've chipped it worse because, of course, enamel is much stronger than composite. So within 2 weeks of placing restorations, we have a similar wear pattern occurring. And so this is a perfect example of why it's really important, however simple and straightforward a case might look, it's important that you're always assessing not just the static occlusion, but the dynamic occlusion. Because this situation, the patient has quite a deep bite, and the opposing lower left 3 has quite a sharp canine tip, a sharp point. And so that is what was causing the wear initially on the upper left 2 when it was unrestored. And now, of course, it's chipped the composite quite quickly. The problem is if you identify this pre-operatively, pre-restoratively, you can identify it, show the patient, and justify some advice to maybe, for example, smooth out the lower left 3 sharp canine tip, for example, or maybe add a bit more to the upper left 3 so that the upper left 2 is not being involved. You look like you really know what you're talking about when you point that out before it's caused a problem. If you don't spot it until you have this situation where the chip has occurred in your composite, then you look like you're backtracking. And when you sort of say, oh, do you know what? I actually think we need to just slightly adjust your lower left canine, patient might understandably sort of think, hold on a minute, why are you now shaving down my tooth when actually you've caused the chip in the upper teeth? It just makes you look like you didn't really know what you're doing and now you're backtracking. So it really makes a difference when you spot the issue from the outset. This is another example of a case by Dr. Ankush, who's from our one of our Centre of Excellence dentists. He does some fantastic cases, and he kindly shared some of his cases with us for our lecture, because this is a great example. You know, you have a patient that comes in and says they want the upper centrals not to look quite so dominant. You want to lengthen the laterals. If you're not looking at the occlusion, you might not spot that actually the lower canines are the problem here, and we're not going to be able to lengthen the upper laterals unless we do a little bit of pre-restorative alignment and improve that anterior occlusion. So here you can see he's managed to do that with a short course of alignment, done the trial smile, and placed the final SmileFast direct restorations. Beautiful. So sometimes a little bit of ortho planning could go a really long way, and it wouldn't take that long to actually achieve that. So works really, really well. Never assume that by doing pre-restorative ortho, that then negates the need to look and check the guidance pathways after the ortho before restoring incisal edges. This is a case that, again, was kindly shared by Dr. Raman Aulick, the specialist orthodontist who's one of my mentors. And I love this case. I think it's so good because you look at how the patient started, and of course, the upper right one distal edge, you're thinking, well, once the teeth are nice and straight, that's going to look almost like a triangle there. That's not looking great. Surely to goodness, now we can restore that edge and give that patient a nice shaped tooth now that we've improved the alignment and given her a better envelope of function anteriorly. But actually, what you need to check still is what happens in terms of guidance with that patient, because with that patient in their current state after the alignment's been completed, when we go sliding to the right with that patient, because the canines are quite worn down, you can clearly see that there's no restorative space to actually build up the upper right one distal corner. So in actual fact, that would chip pretty quickly. So what she actually needs is for the canine guidance to be reinstated. So by building up again, just like the case of Tom's that I showed you. So we need to build up the canine tip there to reinstate canine guidance, give us some restorative space to then be able to restore that distal corner on the upper right one. And when you look at 5-year review, it's still there. You might possibly need to start adding again to that canine, because you can see it's just starting to contact a bit around the upper right one distal aspects of the incisal edge. However, it's lasted and it hasn't chipped, right? So it's really important that you look at function and the guidance pathways, not just pre-ortho, but also post-ortho, pre-restorative, and also pre-restorative if you're not doing ortho, but really, really important. Work out, like I said, become a detective, work out how a particular wear pattern has actually happened, so that then you can actually figure out what needs to be done to safeguard your beautiful restorations that you're planning on placing. Some restorative cases will present to you with multiple challenges and just so many potential treatment options. And something I find that really can sometimes catch us out and provide real challenges is issues with lateral incisors. So upper lateral incisors, I find, are the most common anomaly in the upper anterior segment, and patients can present with any of these situations listed here, and each of these will cause its own sort of individual aesthetic, functional, structure, and even biological challenges, right? So they might be missing both laterals, or they might be just missing one lateral. They might have peg-shaped laterals. They might have one peg-shaped lateral and one missing lateral, or they might have one peg-shaped lateral and one normal size lateral. And all of these situations bring about their own issues. I've just marked out the midlines there for you. So from an aesthetic perspective, midlines, if you're missing both, or if both sides are peg-shaped, then probably midline shouldn't be affected. But if you've got any imbalance, if you're missing one lateral, or if you've got one peg-shaped, one normal lateral, then these are all going to affect the midlines. And of course, that has a big impact on symmetry. From a functional perspective, if there's an issue with your laterals, often that leads to a reduction in overjet, because you've got a mismatch. It's like a Bolton discrepancy between your upper and the lower arches. And so your overjet is often reduced. You've got reduced dental volume in the upper arch. Canine relationships might be affected because of the lack or reduced size of laterals. You might end up in a situation where there's quite heavy anterior edge wear, even though the patient might be class 1 skeletal, class 1 molar, for example. Anteriorly, things might be going wrong because of this mismatch, and you might have crossbite or edge-to-edge relationships with quite heavy tooth wear. From a structural perspective, like I said, you can end up with quite heavy tooth wear and a reduced envelope of function. And sometimes you get recession or fremitus because of that reduced incisal clearance and heavy anterior contacts. So that can all cause issues. Just going to show you one example of this. So this is a patient who primarily came, he's a model, and he primarily came because he was sick of the edges wearing on his teeth and he kept having composite and it kept chipping, and he was aware that he had quite a shifted upper midline. If you look at his anterior envelope of function, when we look at this anterior overjet view, you would never expect that things are that tight when you look at the other images, but he has a lot going on. Again, great dentition, but lots happening because of the fact that he's missing the upper left tooth. That's all that's missing. Upper right 2 is a normal size. Upper left 2 is missing. Someone's done some composite at some point on the upper left 3 to try and make it look a bit squarer, and it's chipping and wearing down because of the issues. So aesthetically, he's got a shifted and a canted upper midline. He's missing his upper left 2. He's got a stained composite on the upper left 3, and he's got quite deficient buccal corridor, especially on the right-hand side, and a very flat smile arc. Occlusally, he's got a very tight overjet and overbite. He's class 2 molar on the right and class 2 canine both sides. He's got occlusal issues. He's got a crossbite on the right-hand side and scissor bite on the left-hand side, and a restricted envelope of function. Structurally, like I said, he's missing his upper left 2, and he's got very heavy incisal edge wear. And we can't really restore it for him. We couldn't just go straight to restorative because he's tried that and it keeps chipping. So there's a lot going on. So what are our treatment options? And when you have these cases, there's loads of treatment options. So for him, we could open up the space to replace the upper left 2 with an implant or a bridge. We could extract upper right 2. That might improve the symmetry, but that's going to make his bite worse. So you might want to then extract a lower incisor to kind of compensate for the fact that we're lacking dental volume in the upper arch and we've got too much potentially in the lower arch. Maybe we'll extract the lingually positioned lower left 4. Maybe we'll do no ortho at all and just go straight to restorative. How's that going to last, given how much wear he's got? He was about 34 when these photos were taken, so quite a lot of tooth wear there. We could do a kind of hybrid approach. We could open up some space around the upper right 2 so that we can make the upper right 2 a bit wider, make it balance out the shape and width of the upper left 3. That might also improve the interarch relationship a little bit because we're adding volume to the uppers. Oh, those two the same, sorry. So there's loads of different options. I think the maximum number of options I've come up with for this case when I'm discussing it with a group is about 15. There are so many different options. But of course, doesn't matter how ideal you might think a specific option might be for a patient. Unfortunately, the human being that's attached to these teeth is effectively going to be the deciding factor. And so for him, he didn't want to have any teeth added. So he didn't want to have any teeth added. He also didn't want to have any teeth taken away. So we couldn't create space to replace the missing teeth. We also couldn't extract any teeth. He wanted something that was going to be as low maintenance afterwards as possible. He wanted to try and improve this midline as much as possible and improve the balance from the left and the right sides, and obviously restore those edges. So in the end, what we did was, you can see here, we have shifted everything around to his right. So we've created a space distal to the upper left 5, also created space around the upper right 2. So we can add volume to the upper right 2 to make it a similar shape and size and volume to the upper left 3. So they both end up looking like laterals, big laterals. And then we were going to restore distal to the upper left 5. So lots of compromises here. But what we've effectively done for him is give him a situation where we can now give him some simple restorative work to balance everything out. So we've restored the upper anterior 5 teeth because he's missing one of those anterior 6 teeth, and done some alignment to help him create a better anterior relationship occlusally, and then we have restored the edges on his lowers as well for him. So big improvement. Is it perfect? No, but that's because he didn't let us give him what potentially could have given him the most kind of perfect outcome, if you like. However, still a massive improvement. And overall, we've taken his overjet up from 1 to 3 millimeters. We've improved his overbite to 30%. We've improved the buccal corridors. Midline is improved, it's upright at least, and it's shifted significantly across. It's not fully centered, but it wouldn't be because he didn't let us do everything that could have helped us to make it fully centered. Scissor bite, cross bites have been corrected. We've created, most importantly, the restorative space that we could restore those edges for him, maintained the buccal occlusion, improved his envelope of function, and improved the smile arc and symmetry. And we've managed to mask that tooth size discrepancy between the upper right 2 and the upper left 3 relatively well, I would say. It's not perfect. big improvement. And most importantly, I think, is the longevity, hopefully, that we've given his restoration. So on the left-hand side, you can see how he started. In the middle column, you can see alignment-wise where we got him to. And then at the end, you can see the restorative work. So both in terms of with the teeth anteriorly apart, but also I think this image, the top row images, are really important there, because that's what's going to give our restorative phase the best possible longevity. So when you're dealing with these kind of cases where there's tooth size discrepancies or Bolton discrepancies, factors to consider are that there's often, in these cases, there's often an insufficiency of tooth volume in the upper arch, and that's then leading to a tight anterior occlusion and considerable tooth wear. It's often a midline asymmetry and just general asymmetry between left and right sides. So what we need to do is aim to add volume to the upper arch, either by replacing missing teeth or creating spaces so that we can add volume restoratively to existing teeth. Aim to improve the anterior envelope of function, because that way whatever restorative work you do will have optimized longevity, and that's really important. And if you're creating space to replace a missing tooth, these days you really have to be careful. People have very high expectations, and this is the kind of thing that can make or break a case, because you mustn't underestimate the importance of a good aesthetic temporary gap filler. Otherwise, what happens is that your patient will run out of steam, they'll feel self-conscious, and they'll make you stop the ortho phase before you're ready, and then you compromise on the end aesthetic. Basically, you might end up with a tiny narrow lateral because you didn't give them a good enough temporary fix aesthetically and they felt too self-conscious. Again, as always, make sure that you're planning for long-term retention around your restorative workflow. Okay, guys, I'm pretty much almost done. I think we're going to be about another sort of 2 or 3 minutes. Having spoken about orthodontic situations that can come about, another thing that we really have to factor in when we're looking at these types of cases is discoloration, because not all teeth are going to be the right color, and we can't always achieve the right color just purely with whitening alone. So sometimes you'll have a stubborn discolored tooth that you want to try and mask. And things to consider if you're trying to restore with composite are we going to use an enamel shade or a dentine shade? Bearing in mind that obviously enamel shades are more translucent than body and dentine shades. That means that if they're in a thick section, they're going to look more gray. They're optically different to the tooth, so the tooth underneath is going to shine through in different ways if the tooth underlying is different, on the shade of the underlying tooth is different on different teeth. If you're using a dentine shade, then they're less translucent than enamel. That means that we can potentially make use of them to help us block out underlying discoloration. Sometimes you'd need to factor in opaque as well. But again, it's not a one-size-fits-all situation. So depending on the thickness of that dentine shade, that's going to dictate the level of translucency or the relative opacity that you achieve. So it's important to work out how much thickness of material you need, so that's all built into your plan. So if you have a discolored tooth that you're trying to mask, the options are that you could add bulk to all of the teeth being restored to stay minimally invasive in your prep work, basically, so that you can add enough thickness to the tooth that's discolored to be able to actually mask it. However, that might give you a potentially bulky looking smile with quite thick restorations. There could be phonetic implications. There could be oral hygiene maintenance implications. The other option might be to prep back the gingival half of that tooth, so the upper left one. We could prep back buccally, gingival half, to create some restorative space to block out the discoloration. However, how thick is the enamel in that area? And bearing in mind that you might then be removing the enamel, you're then going to be relying on bonding to dentine, and what's the bond strength to dentine like versus enamel. So it's important to kind of factor these elements in when you're trying to work out what you're going to do. And remember that the cervical third buccally on a tooth, and that's assuming there's no tooth wear, there's no toothbrush abrasion, is very, very thin. You're looking at 0.3 to 0.5 millimeters, at best. And it gets slightly thicker as you go down the length of the tooth. So the other option might be, if you wanted to go for a version that doesn't involve prepping back what little enamel is there and compromising your bond strength, then maybe you're going to carry out some pre-restorative alignment and consider leaving the discolored tooth ever so slightly less buccally positioned, so a bit more palatally positioned, and that would then give you the extra restorative space without you having to prep it back. However, again, as always, there's lots of things to consider. If you do that, you might need to factor in the occlusion, because you might then leave it slightly in a position of interference, or it might be a premature contact. But also patients sometimes will comment in a situation like that, that the teeth feel stepped palatally, like they're not straight. So if you leave one tooth slightly further lingual or palatally positioned, then there'll be a slight step in the contour palatally or lingually, and the tongue can be quite sensitive to that. So two situations where that might happen. One is when you are, like I just said, trying to leave a bit of buccal space to restore and mask a discolored tooth. The other time it occurs, and this is quite common, is in situations where you've got differential incisal wear and you've had maybe some compensatory over eruption. And if you decide that rather than intruding those teeth and aligning gingival margins, you're actually going to try and align the incisal edges. And if you do that, then what happens is that teeth which have worn to different extents because of their pre-restorative positions will often be slightly different buccolingual or buccopalatal thicknesses. So if you have a look there, that lower left one is thicker at the new incisal edge than the lower right two. That is because the lower left one is more heavily worn. So we're actually looking further down the tooth there, right? So if we then align the incisal edges rather than the gingival margins, then that step around that area is going to be quite noticeable potentially to that patient's tongue. So my preference would always be, if you're going to be doing some alignment, my preference would always be to align the gingival margins. Yes, it doesn't look great initially when you're first aligning the teeth, but it takes you to a situation where you're much less likely to get that step. You can see circles in yellow there. And instead, what you're going to do is re-intrude the tooth that has over-erupted as it's been wearing, and then you can build up the edges. And you will have allowed sufficient thickness in your restorative material there to actually get a decent result as well. One of the issues with aligning incisal edges is that you're still, if you look at the top left image there, that's still going to need some form of restorative work. So not only is it not going to feel smooth to the tongue, you're not really allowing yourself enough space to give a nice blended result with your restorative material, and you're not allowing sufficient thickness for strength and kind of prevention of further chipping or wear. Also, you need to think about, if you're planning indirect or direct restorations, how much incisal overlap you want for your final restorations. I would certainly suggest, if you're planning to kind of rebuild teeth which are worn, you don't want to be having less than 1 millimeter or 1.5 millimeters at least at the incisal edge in terms of restorative thickness. So guys, I'm sorry, I've literally flew by that because there was so much to cover, and I still don't think I've even scratched the surface. But if I've fried your brains, I apologize on this Tuesday night. I couldn't remember what day of the week it was. Let's open up the floor to questions. I think I'm going to stop sharing and we can answer some questions.
Well, first of all, Jasmine, I'd just like to thank you for an incredible presentation. Jasmine told me that she was nervous and she felt underprepared, and then she's just delivered a stellar presentation as always. So thank you for sharing some real gems. And I think the thing I would like about your presentation, Jasmine, was that most of the cases are things that we see routinely in clinical practice. A lot of dentists show cases that you can't treat easily or are so off the scale that no one can treat them. But these are real live patients, aren't they, Jasmine? These are people that you see day in, day out, aren't they?
Absolutely, yeah, definitely. Because, I mean, yeah, it's I think we have to be realistic with our colleagues and show real stuff, really. That's something that we all feel quite strongly about, I think, at SmileFast.
Yeah. So Jasmine, if I can just go through the questions quickly, and then if you can back them back and answer to the team. So Mariam asked the question, which I think is quite a sensible one. At what stage would you recommend doing gingival recontouring? Should it be done at the same visit of the final composite or before? I think I know your answer, but if you answer that one.
Well, ideally, I think I would prefer before, so that you get stability and also optimum moisture control. What would be your thoughts?
Yeah, no, exactly the same. Moisture control, obviously, stability. Also, depending on my next question on that was, how do you normally do your gingival recontouring? Are you using an electrosurgery? Are you using a laser?
Both. I actually prefer my electrosurge. But yes, and I'll have a stent made, so I know where I want the positioning to be. So like just a suck down, basically, clear suck down.
I had heard somewhere that ideally you should try and do it 6 weeks before for perfect stability. However, I think lots of us, particularly in this modern era, I would still say at least a 2-week window. I
Yeah,
wouldn't want to.
yeah. But I think the other thing that's really important is to check and see, is it possible to just do a little bit of recontouring, or does it actually need crown lengthening? And if it needs crown lengthening, send it to a specialist and have that all built into the process.
Next question from Salija. What is the recommendation? Oh, and this is the question I wrote down as well. What is the recommendation for retention for patients with alignment and SmileFast, please?
So it's exactly the same as whatever your retention protocol is for alignment. It doesn't change just because we've placed restorations. And I think retention is probably the most important phase, because that's how you retain the beautiful results that you achieve for the patient. Always important to factor in retention during the time that treatment is being done as well. So never leave a patient without something that they can wear. I would suggest normally, so if you're placing SmileFast Direct, for example, then you can get the lab to get you an Essex retainer made over the 3D setup. So over the agreed design that you're having for your final restorations. You may want to place a bonded retainer as well. I always say never solely rely on a bonded retainer. In fact, I don't even call it a bonded retainer anymore. We call it fixed wire support. So it's giving you a little bit of additional support. It's like an insurance policy, but it's not a standalone element. So you want to ideally, if you're placing a bonded retainer, you wouldn't be able to place that before placing your SmileFast Direct, your composite veneers, because the stent won't seat. So you would ideally, if you're placing it freehand, if you're happy to do that and you feel like you can make it passive, lucky you, show me how you're doing it. Because for upper bonded retainers, I always get them made by an ortho lab. So I'm going to get that made. And then when the Essex retainer is made, I'm going to ask for them to incorporate some palatal relief to factor in my bonded retainer. And I'll fit my bonded retainer at the end of the appointment where I've fitted the SmileFast restorations. And then I might, if I'm honest, I really rely on Vivera retainers because they're my favorite type of retainer. I like how strong they are and how well they retain their form. So I usually then scan for Viveras as well. But if you have a really good quality retainer that you're getting from your labs, whatever it is that you're used to using, that basically.
Just to add to that, I think, Jasmine, yeah, you're right. I mean, obviously, the best retainer, it is important to work with a very, very local lab or restorative lab that can turn around an Essex in 24 hours, because there are times where you just feel like you need it. So speak to your restorative labs. Most of them have got that as well, or a local orthodontic lab.
But the SmileFast lab will give you an Essex retainer made over the 3D setup model as well. So if you are doing SmileFast Direct, you can rely on them to give you a decent Essex.
No, you're absolutely right. Next one, anonymous. When would you, or when you are restoring these cases, what makes you decide between composite or ceramic? It's a bit like speed date. This is fast questions, fast answers.
Yeah, so it depends on several factors. If someone has predisposing factors that cause them to be more likely to get staining, so if they're a heavy smoker, if they've got staining anyway, some people have chromogenic bacteria, then I'm probably more likely to go down the ceramic route. Personally, I love composite. I'll often start things out with composite. I like the fact that we often don't need to prep either at all or heavily at all. But longevity is a big factor. So if someone wants something that's going to stay put and last a good sort of 10, 15, 20 years, then ceramic. If they're happy that composite tends to have a good sort of 5 to 7 years optimum lifespan. Although I am seeing more and more cases that are lasting significantly longer than that. We always aim to under promise and over deliver. So often I'm starting out with composite in those cases. And obviously some situations we can deal with just edges. We don't have to do full coverage. So that would be composite as well.
Yeah, no, same. I'm seeing 6 years, 10-year follow-ups from composite cases that I thought were going to wear down. A couple more questions, then I'll hand over to Lou to sort of take us over the line. Anonymous attendee said, when opening the bite in these cases, how do you decide how much to open and how do you inform the lab? Also, is this done around CR? So a nice, easy question for you there, Jazz.
Yeah, so all of those were about opening. All of it was done with CR. I use a leaf gauge if I'm recording CR with my scanner because I just find that more simple. Hi, Adam. I think that was Adam in the background. Hi. So, oh God, it's an occlusion question, and Adam's just walked onto the screen, king of occlusion.
I know, that's why you're
So
nervous.
unfair. Yeah, so it depends in terms of how much to open up. It really depends on how much we want to add in terms of length, tooth length. So it's kind of case specific. I often prefer to manage these cases orthodontically first, but that's why I showed you a couple of cases where I didn't go orthodontically first, because I think it's only fair to show kind of both examples, really. But yes, it's case dependent, I think.
Cool. Jasmine, I've got to jump off. I just wanted to thank you again for a fantastic presentation. I'll leave Lee to answer, go through the remaining questions. But, I think the biggest thing I've taken from this is the power of orthodontics, because it really saves us from doing a full mouth rehab in many cases. So I think that's fantastic. And I think you've opened a lot of people's eyes to, orthodontic movement rather than drilling teeth. I think it's a massively important and underused skill.
Thanks, Midi.
Thank you so much, everyone. Bye, Jazz.
Thanks,
Bye.
Judy. Bye. Thanks, Jasmine. There's just a couple more questions.
Sure.
So we've got another question here what says, how quickly do you restore teeth after ortho treatment?
I think you have to go in and be quite quick with it, because the patient has gone through this process. The way I plan my cases, often orthodontically, they don't look great initially. Like, I've got uneven incisal edges because I've lined the gingival margins. So I'm factoring in the restorative phase happening quite quickly. Even if it might be that it's interim composite that will then lead to ceramic, for example, if I didn't want to put the ceramic on straight away for some reason, but I get in and restore quite quickly. So there's a very quick workflow. They're whitening towards the end of their alignment phase, and then we start restorative.
Fantastic. This one here, if a patient presents with TMJ, are you happy to treat with orthodontics, or do you do splint therapy first?
Absolutely. So if anyone's got active disease, I'm not starting ortho. So any active disease, caries, periapical disease, TMD, that needs to be addressed first. Absolutely.
I think that's it. People here saying an exceptional presentation with really helpful information. Thank you very much. And I think we've answered that one. Oh, you mentioned, I think this one we've not asked. You mentioned splints to protect your restorations. Is there any particular splints you recommend? B splint ?
Yeah, it's case dependent. So a B splint can be really helpful if you have a patient who bruxes really heavily, and you need some kind of anterior disclusion. But I actually often would start, before going down the B splint route, I would use Viveras with anterior bite ramps, because I find that often helps. So yeah.